I present a phase 3 study comparing an anti-angiogenic drug, sunitinib, compared to placebo in adjuvant setting after nephrectomy for high-risk patients' risk of recurrence. RCC is a relatively frequent tumor, more than 300,000 patients worldwide. And the problem as any tumor type that when you have been surgery, you may have risk of recurrence. It is known that you can achieve that in breast and colon cancer, but we don't have that in renal cell carcinoma. We had drugs like sunitinib, which is very efficient in metastatic renal cell carcinoma, and it's the first-line standard in every guidelines worldwide. And the question was, if you give this drug to the patient that just has nephrectomy, do you improve something, which is less of recurrence? So the study was designed to compare what we do usually, which is placebo, to the sunitinib standard way to give the drugs to these patients for 1 year. So 615 patients were included in the study, randomized 1-to-1 for 1 year, and after we look at what is going to happen. And it's clear that the drug gave an advantage in disease-free survival from 5.6 years to 6.8 years. The p-value is 0.03, meaning significant. And also, when you look at the curves, there is a divergence that came early and go for a longer period of time, meaning that the hazard ratio is 0.761. That means that it's significant. And the increase also of the magnitude of the gain is seen after 3 years and after 5 years when you compare, plus 5.4% at 3 years and to 8% at 5 years. But you give a drug, so you have side effects, so there are more side effects in sunitinib compared to placebo. Overall, they are quite similar. 19% of the patients have side effects in sunitinib, 88% in the placebo. If you look at grade 3 or 4, there are more in sunitinib, 60% compared to 20% in the placebo arm. But the reasons to stop were more adverse event in sunitinib arm and disease progression in the placebo. And that's side effects, but what means quality of life of the patient's reported outcome? And so you can see that there is difference in advantage of placebo. Less fatigue, less diarrhea, less pain, less loss of appetite, and the social functioning is better with placebo. But if you think about what is considered clinically meaningful statistical, it's only loss of appetite and diarrhea in favor of placebo to sunitinib. If you think that overall, it means that we increase the DFS, there is some side effects, and the balance in the way looks to be acceptable in the people who knows how to run the study. So the question would be how to use it. And we have seen it's just a trend that clearly in the higher risk population even, the gain was even more. It was a 2 years advantage in DFS. So now this study goes to regulatory affairs, to FDA and EMA to check if the drug is approved. But today it's only explored in trials, and these drugs are not available for this setting until approval.